No, you make a small incision in the front, and then what happens is you make your approach into the knee, and you slide the kneecap over. I never turn the kneecap, flip it over like that, because that can stretch the quadricep mechanism. So we just slide the kneecap to the side and keep it at what we call 90 degrees. The first procedure I do is prepare the kneecap. So I thin the kneecap out, and that gives me a lot of room to work with the femur and the shin bone. Knee replacement is a very bone preserving procedure. What we do in a knee replacement is here's the thigh bone or the femur, here's the shin bone or the tibia. What we do on the femur is we just take little wafers of bone off the end of the thigh bone just to reshape it to match the geometry of our implant. We then cement on a metal cap on the end of the thigh bone, and in this cement I put vancomycin and tobramycin, two powerful antibiotics which will leak into the knee joint for 9 months to prevent infection. On the shin bone, we take an 8 to 9 millimeter cut below the bad bone. What we do then is we then cement this keel and base plate into the shin bone, and then we put what becomes the new cartilage, this highly cross-linked polyethylene, which is a very durable plastic, into the joint, and that becomes the new cartilage. But before I do that, one of the things I do is I place the first stents or orthostents into the knee. And this allows me to give me real-time readings on how many pounds per pressure on each side of the knee, all the way from full extension to full flexion. Because in surgery, we can be tight on one side in extension and perfect in flexion, or we can be tight in flexion and great in extension, or we can be tight throughout the whole knee. Now, the ligament is a very broad ligament on the inside, and it's about as wide as my finger, and it starts at the bump on the femur here and goes all the way down to the shin bone here. So if we're tight with that ligament, what we can do is we can release that ligament little by little from the bone, and what that does, it relaxes the ligament, allows it to slide up, and we can do it increment by increment until we have the same pressure on the inside as the outside, and that leads to a very balanced knee. Now, what computer navigation does in a knee replacement is you want what we call anatomic alignment or a straight leg, because if I leave you bow-legged or knock-kneed, you're going to put more pressure on one side of the plastic, and it's going to wear out prematurely. The goal is to get a straight leg, so when you bear weight on that plastic, it's distributed evenly across the entire plastic, and it's going to last 15 to 20 years. Like I said before, computer navigation is 98.9% accurate in obtaining a anatomic alignment, whereas our traditional methods were only 68 to 70% accurate. What wears out usually is the base plate on the tibia. And what happens is, what wears is, as we wear, we generate plastic particles in the knee. And as those plastic particles get dispersed throughout the knee, the body eats away at them. And what happens is, when it eats away at the plastic particles, it eats away where the components are attached to the bone and they get loose. So what I do is I see my patients back on a yearly basis, and we take an x-ray and we measure the thickness of the space between the femur and the shin bone, so we can monitor whether that plastic is wearing down or not. If we start to see wear, we can do a exchange of the polyethylene or plastic, and that can ward off the need for a full-blown revision.